Today, we will walk through a clinical case presentation of Creutzfeldt-Jakob disease, commonly abbreviated as CJD, using this structured step-by-step case sheet. Creutzfeldt-Jakob disease is a rare but fatal neurodegenerative disorder caused by abnormal prion proteins that lead to rapid destruction of brain tissue. Unlike many other neurological diseases, CJD progresses extremely quickly, often leading to severe neurological impairment and death within months to a few years. By analyzing each section of this case sheet, patient details, presenting complaints, pathophysiology, examination findings, investigations, and management, we can better understand how clinicians diagnose and approach this devastating condition. Let us begin with Section 1, Patient Details. In this clinical scenario, the patient is a 62-year-old male whose identity has been anonymized for confidentiality. He was recently admitted for evaluation of progressive neurological symptoms. His occupation is listed as a retired school teacher, suggesting that he previously had a high level of cognitive functioning and intellectual activity. This detail becomes important when assessing the degree of cognitive decline, because family members and colleagues often notice changes in memory, reasoning, and behavior more quickly in individuals who previously had strong intellectual abilities. Creutzfeldt-Jakob disease most commonly affects individuals between 55 and 75 years of age, making this patient's age typical for the disease. The condition is rare but universally serious because it progresses rapidly and has no curative treatment. Now we move to Section 2, Presenting Complaints. The most prominent symptom in this patient is rapidly progressive dementia. Unlike Alzheimer's disease, which progresses gradually over many years, CJD often progresses over weeks to months. Patients may initially experience subtle memory problems, confusion, and difficulty concentrating. However, these symptoms rapidly worsen, leading to severe cognitive impairment. Another hallmark symptom is myoclonus, which refers to sudden, involuntary muscle jerks. In CJD, these jerks are often startle-induced, meaning they can occur when the patient is exposed to sudden noise or stimulation. Myoclonus is considered one of the classic clinical features of this disease. The patient also experiences cerebellar ataxia, which manifests as an unsteady gait and poor coordination. The cerebellum plays a crucial role in balance and coordination, so degeneration in this region causes difficulty walking, clumsiness, and frequent falls. Another possible symptom is visual disturbance, which may include blurred vision or cortical blindness. Cortical blindness occurs when the visual processing areas of the brain are damaged, even though the eyes themselves may remain structurally normal. In the final stages of the disease, patients may develop a kinetic mutism, a condition in which the patient becomes unable to move or speak despite being awake. At this stage, neurological function has deteriorated severely. Together, these symptoms, rapid dementia, myoclonus, ataxia, visual disturbance, and a kinetic mutism, are highly suggestive of a prion-related neurodegenerative disease. Next, we move to Section 3, Past Medical History. In this case, the patient has a history of mild hypertension, which is well controlled with medication. Otherwise, his medical history is largely unremarkable. Importantly, there is no family history of neurodegenerative disease, which suggests that this case is likely sporadic Creutzfeldt-Jakob disease. Sporadic CJD accounts for approximately 85% of cases worldwide. Other forms of CJD include familial CJD, which occurs due to inherited mutations in the prion protein gene, and acquired CJD, which can occur through exposure to contaminated surgical instruments, tissue transplants, or consumption of infected animal products. In this patient, the absence of family history and risk exposures strongly suggests the sporadic form of the disease. Now we move to Section 4, Pathophysiology and Mechanism. The central cause of Creutzfeldt-Jakob disease is the accumulation of abnormally folded proteins known as prions. Prions are unique infectious agents because they contain no DNA or RNA. Instead, they consist solely of misfolded proteins that can induce other normal proteins to misfold. In healthy individuals, cells produce a normal prion protein known as PRPC, which is harmless and plays roles in neuronal function. However, in CJD, this normal protein undergoes a structural transformation into a misfolded form called PRPSC. This abnormal protein has a different shape and biochemical properties. It becomes resistant to degradation and begins to accumulate within brain tissue. More importantly, the abnormal prion protein can convert normal proteins into the abnormal form, creating a chain reaction of misfolding. As these abnormal proteins accumulate, they form aggregates within neurons. This process leads to neuronal damage, cell death, and severe brain degeneration. One characteristic pathological feature of CJD is spongiform degeneration, in which brain tissue develops numerous microscopic holes. These holes give the brain a sponge-like appearance under the microscope. The disease also causes rapid brain atrophy, meaning shrinkage of brain tissue. In addition, there is significant astrocytosis, which refers to proliferation of supportive glial cells in response to neuronal injury. The progression of CJD typically follows several stages. First, normal prion proteins undergo conversion into abnormal forms. Next, abnormal proteins accumulate and aggregate within neurons. This leads to progressive neuronal damage and eventually widespread spongiform degeneration of the brain. Now, we move to Section 5, General Examination Findings. During general examination, the patient may demonstrate generalized myoclonus, which can occur spontaneously or be triggered by external stimuli. The patient also displays marked ataxia and an unsteady gait. This is due to degeneration of cerebellar structures that normally coordinate movement. Muscle tone may be increased, producing rigidity or spasticity. Neurological examination may reveal hyperreflexia, meaning exaggerated reflex responses. Additionally, the patient may have extensor plantar responses, also known as a positive Babinski sign, indicating upper motor neuron involvement. As the disease progresses, the patient develops profound cognitive decline, including severe disorientation, inability to recognize familiar individuals, and loss of communication ability. Next, we move to Section 6, Systemic Examination Findings. Neurological examination reveals multiple areas of brain dysfunction. In the cerebral cortex, degeneration causes progressive cognitive deficits such as aphasia, which is impairment of language, apraxia, which is difficulty performing learned motor tasks, and cortical blindness, where visual perception is impaired despite normal eye structures. The cerebellum may also be affected, producing signs such as limb dysmetria, which is the inability to accurately control movement distance. Patients may also demonstrate dystiatochokinesia, meaning difficulty performing rapid alternating movements. The motor system is also involved. Patients may exhibit rigidity, weakness, and severe myoclonus in advanced stages. These findings reflect widespread involvement of different brain regions, which explains the rapidly progressive neurological decline seen in CJD. Now we move to Section 7, Investigations. One of the most important imaging tests is MRI of the brain, particularly sequences such as diffusion-weighted imaging and FLAIR imaging. MRI may show characteristic patterns including cortical ribboning, which refers to abnormal signal changes along the cerebral cortex. Another classic imaging sign is the hockey stick sign involving the thalamus. Another diagnostic test is electroencephalography, or EEG. EEG in CJD often demonstrates periodic sharp wave complexes, which are abnormal electrical patterns that occur at regular intervals. Analysis of cerebrospinal fluid, obtained through lumbar puncture, may reveal specific biomarkers. One commonly detected marker is 14-3 protein, which indicates rapid neuronal damage. Elevated levels of tau protein in cerebrospinal fluid also support the diagnosis of CJD. A newer and highly specific test is RTIC, which stands for real-time quaking-induced conversion. This test detects abnormal prion proteins with high sensitivity and specificity. Together, MRI findings, EEG patterns, cerebrospinal fluid markers, and clinical symptoms help confirm the diagnosis of Creutzfeldt-Jakob disease. Finally, we arrive at Section 8, Management. Unfortunately, there is currently no cure for Creutzfeldt-Jakob disease. Treatment is therefore focused primarily on palliative care and symptom management. Medications such as clonazepam or valproate may be used to reduce myoclonic jerks and improve patient comfort. Patients may also receive anxiolytic medications to manage agitation or anxiety that may occur during the course of the disease. Supportive care is extremely important. This may include nutritional support, often provided through feeding tubes when swallowing becomes difficult. Respiratory support may be necessary in advanced stages if breathing becomes compromised. Healthcare providers also work closely with families to provide counseling, emotional support, and end-of-life planning. Because the disease progresses rapidly, many patients eventually require hospice or specialized nursing care. In summary, Creutzfeldt-Jakob disease is a rare but devastating neurological disorder caused by abnormal prion proteins that lead to rapid brain degeneration. The disease is characterized by rapidly progressive dementia, myoclonus, ataxia, and widespread neurological impairment. Diagnosis relies on a combination of clinical findings, imaging studies, electroencephalography, and cerebrospinal fluid testing. Although no curative treatment currently exists, supportive and palliative care can help manage symptoms and maintain patient comfort during the course of the illness. Understanding the clinical presentation and diagnostic approach to CJD is essential for recognizing this rare disease early and providing appropriate patient care and family support.